CAR T-cell receptor therapy or chimeric antigen receptor therapy is fast becoming a very powerful tool in controlling prolonged remission and curing eventually very refractory cancers, including hematologic and solid tumors. The first entry, as we all know, was into the world of lymphomas that's rapidly expanding into treatment of ovarian cancer, breast cancer, and lung cancer, with expansion of targets for chimeric antigen receptor T cells. We are harnessing the power of the cellular immune response that, to the potential that we never have seen before. And this was possible thanks to decades of development, advances in science of immunology and molecular biology, and our ability to construct T cells capable of fighting tumors that are highly resistant to chemotherapy and other biologic treatments. As I mentioned, the first target was CD19 in B-cell lymphomas that has proven to be very efficacious, and the recent results reported at national and international meetings are very encouraging, with remission rates in highly refractory tumors reaching 50, 60, 70%, 30, 40% complete remission rate, and up to a third of the patients remaining in CR year and a half after treatment, once again when a lot of other treatments failed. The next stage in development of this exciting technology is first controlling the toxicity. We all know that cytokine release syndrome and neurologic toxicity are potential challenges at this point. However, recent advances in this technology, including conditioning prior to introducing T cells and trying to stratify T-cell populations prior to infusion, have changed the ratios of those toxicities in patients with these malignancies. The next step, or even more exciting step now, looking for different targets for CAR T-cell technology and pertaining to the world of hematologic malignancies, and especially this meeting, is trying to identify targets on T cells. And to this date, we have a couple of groups in the United States working on developing this technology that would target CD30 on T-cell lymphomas expressing this antigen, most notably anaplastic large T-cell lymphoma and other T-cell lymphomas that have less prominent expression of CD30. This work was already initiated. The National Cancer Institute group will be reporting initial results very soon. There are some patients already enrolled in that study. Independent group is trying to target the constant chain of the T-cell receptor with the same technology that would be probably more broadly applicable to T-cell lymphomas that are a very diverse group of lymphoid malignancies. The only caveat in doing so, and discussions are being held at different levels, what would happen if we deplete T cells in a human body completely if this technology is too effective? And the lessons can come from prior studies with anti-CD3 antibodies, or even before that with depletion of CD4 population with HIV virus. So with B cells, we have learned that introducing drugs like rituximab, anti-CD20 therapy, remarkably, you can deplete patients of B cells for months and months, sometimes years, and this is only a part of the immune system that's lacking, and the infectious complications are remarkably low rate. What would happen if we deplete T cells? This is the center part of the immune system. Those are answers that we don't have in our, those questions we don't have answers in our hands right now, and only time will show once we start implementing those trials and following those patients closely. But introducing CAR T-cell technology in treatment of T-cell lymphomas is a very exciting time for all of us involved in treatment of these malignancies.